Good morning, everyone, and thank you for the kind introduction. Especially want to thank all the organizers who gave me the opportunity to come and give a talk here. So, without any delay, I'll just go to the topic. So, the topic today is MRI understanding of the shoulder. Now, just an overview of what I'll be taking. I'll just take a small introduction and then go into MR anatomy, and then we'll go into some common pathologies, mainly involving the rotator cuff and the labrum. So the basics first. So when you order an MRI, you won't see this part. Yeah, you only see the images. So there are different types of MRI machines, and we use different magnets. So one of them is the permanent MRI magnet, which is used in the open and extremity MRI scanners. Now, these are low field strength magnets, and they range from 0.15 to 0.4 Tesla units. So the advantage of this is that, because it's an open MRI, you can use patients who are claustrophobic, who are overweight, or very bulky. They can be introduced in the MRI scanner. But the greatest disadvantage is that the spatial resolution is less when you compare with the superconductive MRI magnet. So these are the newer ones, and here we use from 1.5 Tesla to 3 Tesla units magnets. So the advantage of this is that you have increased time and spatial resolution. So you get better clarity, better images of the shoulder or whichever part is being imaged. But the greatest disadvantage is that you can see the bore there is very small. So it is into that part where the head and both the shoulders have to get in. So if the patient is very bulky, overweight, it's very difficult. So that is one of the greatest disadvantages. Now, coming to the positioning and technical aspects. So what you see here is actually it's a coil. So this is the thing through which the pulses, the signal is sent into the shoulder, and it also receives. So this has to be carefully placed over the shoulder, whichever shoulder is being imaged, and the patient has to be positioned in the neutral position where the hand, the upper arm is just against the body and the thumb facing up. So that's the neutral position. Now, a lot of times patients have pain even in this position, and so the whole thing changes. And the coronal, the sagittal sections we take might change, and patient, if is in pain, might be moving, and which will lead to poor quality of the images. And sometimes we use the elbow position. So there the hand is extended and rotated, externally rotated. So for this we use a different coil, which is the body coil. So this is just some of the technical aspects, and coming to the protocol. So now the important thing here is that we do take different sequences. It's just not T1 and T2. There are newer sequences which are much better, and we take them in the coronal, oblique coronal, sagittal and axial images. Now some basics. Now you might all know about T1 and T2, but nowadays we use what is known as the proton density and proton density fat sat images and gradient images. These are much better resolution. So just and then sometimes we use additional sequences, especially post-con. We give contrast, especially if we are suspecting infection, tumors. We do arthrograms with contrast. And there are these sequences which are known as 3D sequences, which give you very thin slices. So with that, you can get really small slices and come to a diagnosis of small lesions. And then there's always the radial imaging of the labrum. These are not usually routinely done, but just for problem solving. Now, coming to the sequences, so you know about T1 and T2. So T1 is mainly to look at the anatomy. So if you want to know the anatomy, you take the T1. You look at the T1 images, and that gives you a beautiful anatomy, the anatomical details. And it's also used to look for the replacement of the normal fatty bone marrow. It also gives a degree of the fatty atrophy of the muscles. Again, when you repair the rotator cuff, if it is showing a lot of fatty atrophy, you cannot do it. It will just re-tear. So it is very important to look for the fatty atrophy on T1. and then looking for bleeding, and also in post contrast you use T1. Now the thing about T2 is that is where you look for the actual pathology. So T1 you look for the anatomy, T2 you look for the pathology. And in pathology, the greatest thing, the things which you actually see is fluid and marrow edema. So that is the importance of T2. Now coming to the proton density, which you might not have had or you heard, this is a later, it's actually a bit sequence which is between T1 and T2. So here it has a higher signal to noise ratio, in which case your cartilage, your tendons, ligaments, and even the labrum is much more well visualized than on T1 and T2. So this is the advantage. So nowadays, if you ask me which sequence do I use PD. I can use a PD, and I can also fat saturated. Fat saturated means all the fat is made black. So only the pathology which is seen as black, white will be shown. So these are the main sequences we use. Now coming to the anatomy, coronal images. So this is just a PD image. Now I'm starting from the beginning, from the anterior aspect to the going posteriorly. So the first image, you can see here, you can see two bones there. So that's the clavicle and the coracoid. So when you see these two bones like that, you know you're in the anterior aspect of the shoulder. And in the same image, you can actually see the multipinate subscapularis muscle, which goes and inserts into the lesser tubercle. Now, as we go a little more posterior, you see the biceps tendon. That's the long head of the biceps tendon. So that's seen as a hypointense. So black structure, cord-like structure, is the long head of biceps tendon, which curves around the humeral head and attaches to the superior glenoid. And at that point itself, you can see a black triangular structure, that is the superior labrum. And okay, in the next image, you can see this cigar-shaped muscle. So that is the just deep to the acromion. So that is the supraspinatus muscle. And if you trace the supraspinatus muscle, you can see that's a black tendon, and that's the insertion of the tendon into the greater tubercle. So and in the same image also you can see the superior labrum. And the inferior labrum is also seen as a black hypoechoic triangular structure. So this and so okay. So then the last, as you go more posteriorly, you can see the spine of the scapula, and just inferior to the spine of the scapula, you have this muscle there. The muscle bulk is because of the infraspinatus, and even lower is the teres minor muscle. So this is just the coronal anatomy. Now coming to the axials. So this is the topmost image, which you can see the acromion and part of the supraspinatus muscle belly. That's all you will see in here. Now as you go just one image down, you can see this structure, cord-like structure, coming from the anterior and coming to the superior glenoid. That's your long head of biceps. And then this black thing, the rounded structure, is the topmost part of the humerus. Any change in the shape, if you see an indentation or a flattening of the posterior aspect of the humeral head, you know that you are dealing with a Hill-Sachs defect. And so that's the scapula. Now coming a little more down, you see the cord-like structure, the muscle here, that just in the anterior aspect. So that is the subscapularis muscle, and just deep to the subscapularis, you can see this triangular structure, that is your anterior glenoid. And this structure here in the posterior aspect of the glenoid is your labrum. This is your anterior labrum, and this is your posterior labrum. Now the structure between the two, if you look carefully, you'll see some grayish structure. That is the cartilage between the two labrums. So all Glad lesions, you'll see some fluid going into the cartilage, then you think it's a Glad lesion. So that is your anterior and posterior labrum. Now coming more anteriorly, you see the bicipital groove. So that's your lesser tubercle and the greater tubercle, and between you have the biceps tendon. You can see some fluid between that. So there you can see these structures in this. Now coming a little more down, you can see the attachment of the anterior band of the inferior glenohumeral ligament and the posterior band of the inferior glenohumeral ligament. You can see the inferior labrum and the posterior inferior labrum. There's some fluid in the joint axillary recess and some fluid around the biceps tendon. So just that was just the axials. Now coming to the sagittal. Now the more we don't use sagittal very often, but the most important indication of doing the sagittal is to look for the muscle bulk atrophy, as I previously said. You can see this is the most medial aspect. So you can see the supraspinatus, infraspinatus, teres minor, and anteriorly anterior to the scapula you have the subscapularis muscle. So coming more laterally, again you can see the supraspinatus in the tendon slowly myotendinous junctions. You can see the anterior and posterior glenohumeral ligaments. So that's the subscapularis. That's the rotator interval between the supraspinatus and the subscapularis, and that's where you will have your the glenohumeral ligament coming there. So that's your rotator interval, and your biceps tendon is just deep to the supraspinatus. Now coming more medially, you can see, you can just trace the muscles, the same things are seen, and here at the end you can see the attachment of the rotator cuff muscles, yeah, and that's the attachment of the subscapularis. So this is a brief anatomy of the MR anatomy. Now coming to the most interesting part is the rotator cuff pathologies. Now mainly the pathologies involve tears and of the rotator cuff, and these can be divided as partial and full thickness and complete. So this is just a diagrammatic image of the partial tears. So this is how that's the normal supraspinatus, and that's the tendon coming and inserting. So in partial tears, as you all know, there's this, as we previously heard, there's the bursal, articular, and the interstitial or the intrasubstance tear. So when you have a tear which does not involve the whole thickness of the tendon, you call it as a partial tear. So here you can see this is on the articular surface, and that is a tear which involves the articular surface. Now it is very important, as I think scopists, to come and probe the underneath of the these subscapularis, as these may otherwise may be missed, because most of the tears you will be seeing is the bursal surface tears, which can be easily picked up. Now this is a tear which is not picked up on arthroscopy, and only we radiologists pick up. That's the intrasubstance tear or the interstitial tear, which it does not communicate to both the surfaces. So it's just inside the substance. It can actually extend into the insertion point or even into the muscle, where you can get a ganglionosis formation and all that. So that is regarding the partial tear. And okay, I'll just go and show you some images. So this is an image, MRI coronal image. You can see that there is fluid. So how do you identify a tear? So normally, as I said, all these tendons, ligaments, labrum, they are all black in color, hypointense. But if you see some fluid signal which is white in color extending into the normal anatomical position, you call it as a tear. Now you can see here, you can see the fluid signal extending from the bursal surface inside. So that is a bursal. So it's not extending all the way to the articular surface. So this is a partial tear, the bursal surface partial tear. Now there's some grading. If it's less than 3 mm, it's grade 1, 2, and 3. So I won't go into all that. Coming to this is a case of articular surface tear. So you can see, so this is the articular surface, and here just at the insertion at the greater tubercle you can see a hyperintense line. That's fluid signal. That's because of a tear, and this is not extending all the way up to the bursal surface. So that's the articular surface partial tear. Now this image is an ultrasound image. So even though it's an MRI, I'm just talking about ultrasound. I'll tell you more about that. So the same tear can actually be identified on the ultrasound. So this is that's the greater tubercle. That's the articular surface. The black hypoechoic area is the tear which is not extending all the way up to the bursal surface. So it's a partial articular surface tear. interstitial tears. So when you have intact bursal and articular surface, but you see fluid signal or tear in between the two, that's called a interstitial or a intrasubstance tear. And sometimes, as I said previously, it can actually extend all the way into the muscle. So this is how you'd see a interstitial tear. Now coming to full thickness and complete tears. Now, full thickness tear is a tear which extends from the articular surface to the bursal surface, but it does not involve the whole width of the tear, of the tendon, of the rotator cuff. So that is what is known as a full thickness tear. Now, in a complete tear, you have a complete tear is a full thickness tear which actually extends all the to the width of the rotator cuff, the tendon. So that's when you call it as a complete tear. Now, so these are different types of tears, the shapes, as previously Dr. Harish had shown. So that's the U-shaped tear, which actually extends beyond the rotator cable. So these are quite large tears, and that's how you repair a U-shaped tear. And this is the most common, the crescent-shaped, which is usually seen more just close to the insertion and does not extend beyond the rotator cable. So that's a crescent-shaped tear, and that's a L-shaped tear. Again, you can see how these are repaired. So just some images. So this is a crescent shaped. So you can see that's where the rotator cable is. So it's just a small tear near the attachment. So this is a crescent shaped tear. And here is a full thickness tear, which is an L-shaped tear. So here the anteroposterior width, the dimension of the tear is smaller to the transverse diameter. So that's when you see such a tear, especially in the the sagittal image, that's when you call it as a L-shaped tear. So we can, to an extent, identify the types of tear on MRI, even though, of course, arthroscopy is much better. Now, so again, full thickness tears can be given as small, medium, and large, or even massive when it is more than 5 centimeters, involving more than one rotator cuff. So here, this is an example of a U-shaped tear where it extends all the way up, involving the rotator cable on the coronal, you can see, and on the sagittal, you can see it extends all the way, involving the whole of the tear, the footprint. So that is a U-shaped tear. So the same thing we did. It came for ultrasound first. We did the ultrasound. We identified the full thickness tear on the. This is the sagittal image. You can see the greater tubercle. That's where it inserts, and in that point you don't see the normal tendon, and that was a full thickness tear. And on the coronal, you can see there's total absence of the tendon. So that was a full thickness tear, and this is proven on MRI. Coming to a complete tear. So a complete tear, as I said, it extends. It's a full thickness tear which extends through the width of the tendon. So here you can see that there's no tendon there. It is all retracted up to the glenoid, and so that is where you would actually see the tendon. So the same thing, we had actually done the ultrasound. We saw that the deltoid muscle is actually flush over the humeral head. So that was a full complete tear. So a massive tear is when you have more tendons involved. So there's a full thickness, complete tear of the supraspinatus. And if you look very carefully here, that's where the subscapular is, which is you see that there's tear involved in the attachment, and in the next image, you see the bicipital groove, but you don't see the normal biceps tendon. So it's involving the supraspinatus, subscapularis, and even biceps tendon. So it's a massive tear. Now, depending on the retraction, there's this PATTE's classification. In stage 1, it's retracted just near to the insertion, the supraspinatus. And in stage 2, it is seen just over the level of the humeral head. And in stage 3, it extends to the level of the glenoid. So that's PATTE's classification. Now, more important is the Gautelier's classification of muscle fatty atrophy. Now, normally the muscle is seen like this. If you draw a line along the Y scapula, you can see it bulges above the line, the tangent line here. So that's a normal. In grade 1, you have fatty streaks. So some white lines will be seen in the normal muscle. So that's just grade grade 1. In 2, there's up to less than 50% of these fatty streaks, and you can see the bulk of the muscle starts decreasing. And in 3, there's more than 50% fatty atrophy, and in 4, there's definitely more than 50%. So in this grade 4, it is I don't think it's possible for reconstruction. Now coming to the instabilities, the anterior dislocation. So this is an example, the radiograph. So that's that's the indentation on the humeral head. That's the Hill-Sachs and the BANKART. That's a bony BANKART. Now coming to the Hill-Sachs, it's seen as an indentation on the humeral head, and it's a defect. So you can actually see in the first image, you lose the normal circular shape of the humeral head, and that's the Hill-Sachs. Now there are the BANKART, where you have the tear of the labrum. So this is just the diagram, which also involves the periosteum. So when the labrum is detached or torn and involving the periosteum, you call it as a BANKART. The same thing you can see on MRI, where the normal morphology of the anterior inferior is lost of the labrum, and there you can see high signal intensity within the lesion. So these may involve with bony fractures, where you call it as bony BANKART. Now coming to on-track and off-track lesions, this is mainly to assess the increased risk of Hill-Sachs engagement or recurrent instability. Hill-Sachs defect that is smaller. So you can see if the Hill-Sachs defect is smaller than the glenoid track, then it is known as the on-track. So that means there's no engagement. But if the Hill-Sachs is larger than the glenoid tract, then this is going to be engaged and will lead to instability. So this can be on MR and on CT we can calculate these measurements. So again, by measuring the Hill-Sachs index and the glenoid tract, we can actually say whether it is engaging or not. So on track or off track. Since I'm short of time, I won't go into all this, but there's just a PERTHES lesion where the periosteum is intact. There's a labral tear with periosteal attachment. In ALPSA, again, the periosteum, the sleeve is avulsed, the labrum is rotated medially and inferiorly. So that's a ALPSA lesion. Haggles, again, we heard that's the normal inferior glenohumeral ligament, and you have fluid here, that's the normally, but when that is torn, you can see the fluid escaping down extracapsular, and that is because of the tear of the inferior gleno. That's a Haggle. And when there's bony involvement, you call it as a Bagel. Posterior instability, that's the normal, light bulb sign. And you get the reverse of the signs. So you get indentation on the anterior glenoid, and you get a posterior labral tear. So you can see fluid signal going into the triangular shape of the posterior inferior. So that's a posterior labral tear. Coming to slabs, the superior labrum, the slabs can vary from minor fraying to major involvement of the other labrum and capsular structures. So that's how the normal triangular structure of the capsule, the supraspinal, the superior labrum is. There's grading from 1 to 13. I'm not going into that. The most commonly you see is some fraying, which is type 1, and on MR it's just seen as some signal change. And in 2 is the most common, where the tear actually extends into the labral substance. That's grade 2. So that was the arthroscopic. And grade 3 is where you have a bucket handle, where the labrum is torn and is inferiorly detached. And in 4, you get it extends into the biceps tendon. This is a fluid signal lesion in just around the glenoid notch, and that is a spinoglenoid notch cyst. Most important thing here is that's the supraspinatus, that's the infraspinatus. You can see there's some signal intensity, it is atrophied. This cyst ganglion is actually compressing on the suprascapular nerve and causing the atrophy of the infraspinatus muscle. At the inferior glenoid, you can see cystic structure, that is an inferior paralabral cyst because of, if you look very carefully, there's no edema fluid. It's a chronic tear leading to a paralabral cyst. Shoulder impingements, you can see anything that decreases the subacromial space will lead to impingement. So acromioclavicular joint arthropathy can impinge on the supraspinatus, and that is what we are seeing here, leading to its tendinosis and tear. And this is a downsloping acromion, which is again impinging on the supraspinatus and decreasing. In adhesive capsulitis, you actually see thickening of the inferior glenoid with change in the morphology and signal intensity. You can get some scarring within the rotator interval. All these will tell you that there is adhesive capsulitis. So thank you, and sorry for taking 5 minutes extra. And I think it is good to have a good interaction between ortho and radio. We can learn much more in these. Thank you.